So the question was asked about the use of triple trays for single tooth posterior restorations. Is this a good idea or a bad one? Well, it depends. Dr. Stephen Hart did this wonderful survey of 150 dentists and technicians to find out the reasons crowns were too high and required adjustments. And what's really interesting is when you parse out their answers, you see that laboratory technicians will blame the cause as something beyond their control. Younger dentists typically blame technology or the material itself, whereas older dentists typically understand that there are more interactions at play and that could be one of many things. If we simply look at the numbers, and this was published by Glidewell's Chairside magazine in April of this year, they reported that 85% of the restorative cases received by them utilized triple tray impressions. What's really important to note is that Glidewell claims to produce between 75 and 80% of the indirect restorations in the United States today. And if we're going to use a triple tray impression, we're limited to a class 1 instrument, which is fine. Understand the indications for use. Single units, patient has no functional problems, and we're not making any changes from the existing occlusion. But the problem is the adjustable features. There are none. And understand that the rotational centers tend to create positive errors in both the sagittal and horizontal planes. We are obviously limited to eccentric mounting only, and we must have adequate surrounding dentition. The question often asked, do full arch impressions provide more information? Please understand what a positive error is. A positive error occurs when an instrument undercompensates for mandibular movement. And this results in the fabrication of a positive feature on the occlusal surface where that feature should be smaller or non-existent. So we're higher eccentric and we have lateral interferences. Something that you really need to understand in the use of a triple tray is no matter what the triple tray is that you select, that when the patient closes, that complete closure will never occur with any of the trays. And that's because the material that separates the upper and lower. So if your OCD is real high like mine, you'll grab a set of digital calipers and you'll actually go through and measure the thickness of this material in all the triple trays in your office. So that's one consideration. The other consideration is what is actually happening at the lab. And this is typically what you'll see in assembly line arrangement. The one technician is going to go ahead and mount all the cases, but maybe the tray selection by the dentist was a bad idea. Let's take a look at this case. Well, we have posterior information, we have anterior information. There's a pretty good likelihood that this restoration will go in with a minimal amount of adjustment. How about the thought process behind this? Do you think that this restoration is going to go in with satisfactory results? How about this one? Any concerns with this? And I say there's some very high concerns. And what's the reason? Well, the reason is that this preparation has been pinned. And this is a huge problem simply because that means this model got wet at least 4 times. And we know every time you wet a model, it can add to linear expansion. In fact, linear expansion can be up to 0.14 millimeters every time you wet a model. So if it's wet 4 times, that's almost 5 millimeters of potential change. Plus, if you look at that, the only way to get the cast to articulate was to put the pinned cast back into the double bite impression and pour it. We understand that no lateral or protrusive movements made on a simple hinge will replicate nature. So if we take a look at this nice little conservative MO inlay onlay, and yes, I still use gold, Mike Melkers always talks to the dot. It's about the centric stop that's important. And we know that besides centric, that we have working and non-working pathways. And in this case, we carved a nice deep supplemental groove in the non-working pathway. And we had our technicians, because we know that simple hinges will create positive errors, actually move the stamp cusp more distally so that we would have a minimal amount of adjustment in the mouth. So move stamp cusps distally on upper teeth, have them move them more mesially on mandibular teeth. But it is, at the end of the day, all about the dot. And this dot is important. It's important to hold centric. Dr. Pankey said it was simple. When a patient closes, the teeth should all touch without deflection. And if you try to accomplish tripod contacts like they tried to teach us in school, there's a greater likelihood that you would have a deflection than if you simply had a single centric stop. And we know that the single centric stop is effective at holding adequate support. You can either buccalize or lingualize the occlusion with a cuss tip occluding on a flat plane. Now, Parker is probably the most quoted literature on the subject, and his study of comparison of occlusal contacts in MIP from a triple tray and full arch models, he found the average occlusal error for articulated casts made from a dual arch impression is 5 microns, opposed to an average error of 72 microns for mounted casts made from full arch impressions. What you have to understand is the accuracy is completely dependent on the patient's ability to close into MIP. And in his study, all the patients were graduate prosthodontic students, so they understood what MIP was. The issue happens is when the tray's in the mouth and there's something between the teeth, the patient may not recognize how they're closing and not close into MIP. So it's very possible for patients to miss MIP. Now, the real gem in the whole article is this. He wrote, the dentist must verify the relationship and evaluate the impression by transillumination after removal to ensure the desired closure. And this is a brilliant concept. Here are 2 impressions. The one on the right is my preliminary impression to fabricate my provisional restoration. The impression on my left is that of my definitive preparation to be sent to the laboratory. But what's a wonderful thing to do and an important thing to do, again, it's all about the dots, just hold them up to light and see if you have all the same centric stops in both impressions. And that's a good indication that you are an MIP, especially since we prepped a lower tooth, gave a mandibular block, and the patient has no idea of if they are an MIP on that side. Now, let's speak to the use of a plastic tray, like I used for the preliminary impression, versus a metal tray, which I used for my final impression. There are a lot of in vitro studies, lots and lots and lots of desktop studies. There are very few in vivo studies, and I found this one, and it was quite eloquent. They just simply took a implant abutment transfer, put it in the mouth, and took impressions. And they looked at the accuracy of metal and plastic trays utilizing PVS and polyether. And what they found is that the metal dual arch trays provided the least amount of distortion, and the plastic dual arch trays with polyether created the greatest distortion. And this is what they found. This was measuring in microns the width increase of the dye measured poured from the impressions. And so perhaps the biggest problem, and I think Lou identified this, is that polyether has very little elastic recovery, and that in the impression procedure, if a material that you select, like polyether, can't resist the forces generated as it's removed from the oral cavity, it could permanently deform and result in greater error. So perhaps it's not the tray, as this information and data shows, it's the material you select to use with the tray. And understand triple trays only work when the desired treatment position for the teeth is in MIP. And it works because the teeth are in contact and the mounting is independent of the pore, and this allows for more accurate stops. If we're going to use full arch models for single tooth, they must be equilibrated before the occlusion on the restoration can be fabricated, because a positive error on the cast is going to result in a restoration that is not correct. What say you when you see something like this? Well, the biggest issue is that the posterior second molars, terminal second molars, are prepared. So it's probably not best to use a triple tray and a simple hinge articulator when the distalmost tooth in the arch is done. Because from a functional standpoint, the second molar typically gives us a lot of guidance in terms of the anatomy and cuspal inclinations that can be used to guide us in the fabrication of any teeth anterior to this tooth. So here's a clinical case where I'm replacing some crowns circa 1980 metal ceramic. The second bicuspid was lost and an implant has been put in place. And we simply are going to take a centric bite in MIP only over the prepared teeth. And we are going to then make sure that we trim it on the tooth side to cusp tips only, and on the prep side so no soft tissue contact occurs. This will be used to mount our casts, and we're going to mount our casts on a class 3 instrument using a Facebook transfer full arch model. So now we have the anterior guidance information on the contralateral side from the cuspid, as well as all the guidance information on the same working side. And this is the case delivered, tried in before any adjustments are done. We can see we have nice centric stops on the first molar, the first bi, and you notice the heavier centric stops on the second bi. And that's to be fully expected since that is an implant restoration and there is no PDL. So from adjusted to here to completion is very minimal and quite easy to complete. And the definitive restorations is seen in the mouth. So the decision really depends on the functional risk factors of the case. The more functional information we send to the laboratory, the higher our chances of managing the case precisely occur. Thank you.